So friends, welcome back. I am Professor GN Purohit from the Department of Veterinary Gynecology and Obstetrics, Rajasthan University of Veterinary and Animal Sciences, Bikaner, India. And today in my next lecture, discuss something about ovarian cysts in the domestic animals. Now, ovarian cysts are the frequent cause of abnormal estrous behavior and infertility in dairy and beef cows. The incidence varies between 5 to 45%, and mostly the cows develop ovarian cysts during the postpartum period. As per one estimate, 14% of all cows develop cysts during their lifetime. Now, it is pertinent to understand the ovarian events caused by the pre-ovulatory LH surge. See, the pre-ovulatory LH surge causes increase in the PGE2, which causes increased blood flow to the ovary and the dominant follicle. Then there is increase in the prostaglandin F2 alpha. This causes increased contraction of the ovarian smooth muscle and releases the lysozymal enzymes. The contraction and the lysozymal enzymes cause increased follicular fluid pressure and weakness of the follicle wall. Then the pre-ovulatory LH surge also causes the shift from the estradiol to the progesterone of the dominant follicle. So this results into increased progesterone, and increased progesterone thereby causes increased collagenase, which also weakens the follicle wall. Then the increased blood flow to the ovary and the dominant follicle, it causes edema, and this also increases the follicular fluid pressure. The pre-ovulatory LH surge, it also results in the gap junction breakdown between the granulosal cells and the oocyte, and removal of the meiotic inhibition and release of the first polar body. Now the oocyte is ready, and collectively this results into ovulation. Now it's the breach in the ovulatory mechanism probably which results into the ovarian cyst. The exact etiology of ovarian cyst is not known, but endocrine dysfunction and mechanical interference are the two postulated causes. The possible mechanisms include a low luteinizing hormone, the lack of luteinizing hormone receptors, the lack of response to estrogen, then the increased suprabasal progesterone. It has been postulated that the stress causes increased release of progesterone from the adrenals, and this is what is known as the suprabasal progesterone. Then increased adrenocorticotropic hormone, increased prolactin, and decreased thyroid function. Then another possible etiology is the endogenous opioid peptides and the low glucose and insulin. A report in the recent past have mentioned that it is something related to the lack of regression of the dominant follicle formed during the immediate postpartum period, and this results into persistence of a dominant follicle, thereby resulting into formation of a ovarian cyst in cows. The predisposing factors for ovarian cysts are common in dairy cows. The close confinement increases the incidence. The ovarian cysts are common during 2nd to 5th lactation, and high milk production increases the incidence. Then high estrogenic feeds and stress at parturition all may predispose cows to development of ovarian cysts. Two types of cysts have been mentioned for dairy cows, the follicular and the luteal. The ovarian cysts may be present on one ovary or they may be multiple and present on both the ovaries. The clinical findings with cows having ovarian cysts include anestrus, nymphomania in follicular cysts, frequent and prolonged distress, masculine behavior, increased 17-keto-steroids and adrenal virilism, the formation of a sterility hump, edematous vulva, vaginal prolapse, mucometra, enlarged uterus, and Swiss cheese appearance of the endometrium and clitoral hypertrophy. It has been clinically seen that cows with ovarian cysts and not treated, nor the cyst has resolved spontaneously, may have normal estrous cycles, but yet have ovarian cyst on one or both the ovaries. The diagnosis of cysts depends on the transrectal palpation of the enlarged ovaries and fluid-filled structures. Transrectal ultrasonography can supplement and can help in the diagnosis of ovarian cysts. The plasma progesterone profiles can differentiate the follicular and the luteal cysts. It has been mentioned for dairy cows that cysts are fluid-filled or hard structures 2.5 centimeter or more and persisting on the ovarian surface for 10 or more days. So all these criteria can help in the diagnosis of ovarian cyst in dairy cows. Most cows develop cysts during the postpartum period and some may resolve spontaneously. The persistence of cysts on the ovaries for prolonged periods results in pathologies in the uterus and it results into development of mucometra, adrenal virilism, bull-like appearance and sterility hump. The possible etiology of follicular cysts is that external factors increase milk, the harsh season, heredity, affects the anterior pituitary, and this results into altered granulosa cells which produce increased ACTH, resulting into adrenal hypertrophy and increased aldosterone. This results into salt retention and then high follicle stimulating hormone and low luteinizing hormone result into a anovulatory follicle. The production of estrogen, the continued production of estrogen by follicular cysts will result into increased follicular sodium ion and increased water retention. This will result into inhibition of the follicular atresia, and increased production of estrogen also results in a nymphomaniac behavior, what they say the increased sexual desire of dairy cows, prolonged estrous cycles, or maybe prolonged estrous periods. The therapy of ovarian cysts, the spontaneous recovery have been observed in cows with ovarian cysts. Then there was a time when manual rupture of the ovarian cyst was suggested, but currently manual rupture of the follicular cyst is not suggested because that may result into uncontrolled hemorrhages and development of the attachments of the ovary with the surrounding structures. The administration of iodine preparations, potassium iodide 10 to 15 grams for 5 days, or the subcutaneous administration of elemental iodine has been suggested in an attempt that ovarian cysts develop because of the hyperfunction of the thyroid. HCG injections have been suggested starting from 1500 to 5000 units administered intramuscular or intravenous. Then GnRH is the method of choice, the treatment of choice, 40 to 100 microgram administered intramuscular or intravenous. More recently, the administration of GnRH followed by administration of a prostaglandin 7 to 10 days later have been suggested. The administration of GnRH or an HCG results into the luteinization of the cyst, and the luteal tissue can then be resolved by administration of the prostaglandin 7 to 10 days later. The oral administration of altoxin was studied in one recent study, and they found that the cows with ovarian cyst have a hyperfunction of the thyroid, and oral administration of altoxin along with other medicaments can help in a speedy recovery. Then cysts which are luteal in nature, prostaglandin injections have been suggested. The administration of progesterone 500 milligram intramuscular or as a vaginal implant have been suggested to improve the luteinization of the ovarian cysts, particularly the follicular cyst. Then the ovsing protocol has been suggested for the therapy of ovarian cysts. Administration of progesterone implant plus prostaglandin plus a GnRH have currently been suggested because it's difficult to delineate the type of cyst. Some of the scientists and clinicians, they suggest the combined administration of prostaglandins, GnRH and progesterone. A prophylactic administration of GnRH 8 to 20 days postpartum have been suggested to minimize the incidence of ovarian cysts in dairy cows. Then ovarian cysts in the bitches. Ovarian cysts are detected in older bitches, generally at ovariohysterectomy. They are frequently of parabursal origin. In this ultrasound picture, you can see this is the ovary and this is the cyst which is outside the ovarian boundary. Bitches with ovarian cysts may show prolonged bleeding or prolonged estrus. Estrogen producing cysts may sometimes produce persistent estrus with vulval discharge, flank alopecia and hyperkeratosis. Bitches are presented to the clinic due to prolonged estrus or vaginal discharge outside of the physiological estrus cycle. Vulvar discharge is serosanguinous or sanguinous purulent. In this table, we show that in one study, it was found that multiple cysts on both ovaries were recorded in majority of the bitches in the study. Multiple cysts on a single ovary were the second frequent problem in bitches, and multiple cysts on one ovary and solitary cysts on contralateral ovary were recorded in 3 bitches. Solitary cysts on both ovaries were recorded in 5 bitches, and solitary cyst on a single ovary were recorded in 8 bitches. So multiple cysts on both ovaries are frequently common in bitches. Canine ovarian cysts have been classified as follicular and non-follicular cysts. Cysts from rete ovari and parovarian cysts are the non-follicular cysts. Here you can see the follicular cyst, a lot of enlarged follicles present on the canine ovary. When we dissect it out, you can see hollow follicles, and in the lower picture you can see the parabursal cyst of the parabursal region location and cyst, the rete ovari cyst. Then bitches with cysts may show persistent vaginal cornification greater than 21 days. Here in this ultrasound picture, you can see the follicular cyst on the ovary and then along with the normal follicle you can see two ovarian cysts present in this picture. The administration of GnRH 25 microgram intramuscular have been suggested for the queen and 50 microgram intramuscular have been suggested for the bitch, or luteinizing hormone 2.5 milligram for the bitch for the queen and 5 milligram for the bitch have been suggested. Other treatment options of ovarian cysts may be the aspiration of cystic fluid via laparotomy or ultrasound guided aspiration. The latter was successfully performed in 6 bitches, of which 3 subsequently conceived. A subtle option could be the performance of ovariohysterectomy if the bitch owner does not desire to have further breedings. Then ovarian cysts in sheep and goat. Cystic ovaries appear to be common in goats than in sheep. In one study, 2.4% or of more than 1,000 female goats examined at slaughterhouse had ovarian cysts. Owners often make the diagnosis based on short cycles or nymphomania. So cystic ovarian disease probably is overdiagnosed in sheep and goats. The affected goats may evidence pawing the ground and nymphomania or an estrus. Ultrasonography and hormone profiles can aid in the diagnosis. The therapy involves the administration of HCG, GnRH or combination of HCG and progesterone, or GnRH and prostaglandins, or GnRH, progesterone and prostaglandins. In ovarian cysts in sows, around 8 to 10% of sows have a poor production record due to cystic ovaries. Initially, these animals have a normal first or second litter, and then instead of showing an increase in litter, the number of piglets decreases. The animal exhibits irregular estrus or no estrus at all. Follicular cysts, small and multiples, develop from mature follicles. Cysts not ovulated and neither were partially luteinized. Follicular cysts originate from follicles which do not ovulate but continually grow until they exceed a diameter of 11 mm. Luteal cysts arise from ovulated follicles, presumably due to the premature closure of the ovulation site, and are assumed to develop from overgrown corpora hemorrhagica. Single cysts can coexist with normal follicles and corpora lutea and appear to cause little interference with the cycle length. Multiple large or small cysts with corpora lutea on the ovaries are common and are always associated with temporary or permanent infertility. There are no pathognomonic clinical signs for cystic ovaries in pigs. Symptoms of this disorder include an estrus and irregular and or prolonged estrus cycles. However, it leads to decreased farrowing rates as well as smaller litter sizes, and it is a source of subfertility in sow herds. The cyst can be diagnosed by transabdominal ultrasound. Here you can see the ovary having multiple cysts, and in this picture, which shows the abortoid derived ovaries of sows, the lower ones are the normal ovaries and the upper ones show the ovaries with follicular cysts. The percentage representation of ovarian cysts in one studies, cysts of luteinization were much more common compared to corpus luteum cyst and the follicular cyst in sows. Positive response in sows with large follicular ovarian cysts has been shown to the treatment comprising of 2 administrations of 100 microgram GnRH at a 12-hour interval. HCG and PG can also be used. Now we talk of ovarian cysts in mares. Anovulatory follicles in mares have some characteristics that are similar to the cystic ovarian syndrome in cattle. Ovulation failure occasionally occurs during the physiologic breeding season. Anovulatory follicles may be large, 5 to 15 cm in diameter, persist for up to 2 months, and result in a prolonged period of behavioral anestrus and a long interovulatory interval. The incidence of anovulatory follicles increases with age. Mares 16 to 20 years old were noted to form anovulatory follicles. Here in this ultrasound picture, you can see the anovulatory follicles in the mare. The one on the right hand side is showing specks of echogenic tissues within a anovulatory follicle. A majority of anovulatory follicles eventually become luteinized, although some remain as follicular structures. Progesterone levels may be used to determine the luteal status of anovulatory follicle. The possible symptoms of ovarian cysts in mares include behavioral changes, especially corresponding with fertility cycles, refusing to accept a rider, refusing to accept a stud, erratic heat cycles, and infertility. A majority of non-luteinized anovulatory follicles will spontaneously regress in 1 to 4 weeks. Administration of prostaglandins will result in the destruction of the luteal cells in mares with luteinized anovulatory follicles, a rapid decline in serum progesterone levels, and a return to estrus. Another important condition which confuses the veterinarians with ovarian cysts in the mare is the granulosa theca cell tumor. Granulosa theca cell tumors represent the most common group of tumors that develop on the equine ovary and probably comprise 2.5% of all equine tumors. It has been reported in all ages and breeds, even in pregnant mares, but are common in 5 to 10-year-old mares. They arise from sex-caused stromal tissue within the ovary. Most are benign and unilateral, but hormonally active. Mares with GCT usually exhibit one of 3 types of behavior depending upon the type and amount of hormones produced by the tumor. These are prolonged anestrus, persistent or intermittent estrus behavior, or stallion-like behavior. Mares exhibiting the latter may also have a crested neck and enlarged clitoris. Serum inhibin and testosterone are elevated in 80% and 54% respectively of mares with granulosa cell tumors. A serum testosterone concentration of greater than 100 picogram per ml is considered diagnostic for a GCT in a mare. The diagnosis of GCTs in mares is based on clinical history, including changes in behavior, rectal palpation, ultrasonography, and serum hormone analysis. By transrectal palpation, the affected ovary is enlarged. It may be cystic and or abnormally firm. An ovulation fossa is typically absent or not palpable. Palpation of both ovaries is important because ovarian enlargement may be associated with other conditions, for example, hematoma. If the contralateral ovary is active, the enlarged ovary probably does not have a GCT. GCTs can be multilocular and honeycomb to dense, knobby, or smooth. Some GCTs may appear with a single fluid-filled cyst or a solid ovarian mass. Here you can see the mare with abnormal behavior, and these are the ultrasound pictures showing honeycombing in a ultrasound scan. Treatment for granulosa theca cell tumors is surgical removal of the affected ovary. Most mares return to normal estrous cycles within 6 to 8 months following the ovarectomy, with a range of 2 to 16 months. Now we discuss something about the ovarian cysts in female camels. In fact, the term cystic ovaries does not always apply to Camelidae because some females develop follicular cyst if not bred, as ovulation in these species is induced. Incidence of ovarian cysts in she camels varied from 0.9% to 3.39%. The follicular, luteal and hemorrhagic cysts are a normal evolution of the non-ovulatory follicle, the functional cysts. The presence of these cysts indicates ovulation failure which may be caused by inadequate LH release in response to copulation. You can see here in these pictures, these are the follicular cysts, these are the hemorrhagic cysts having blood inside, and these are the luteal cysts on the camel ovaries. Camels with ovarian cysts evidence a cocking behavior for prolonged periods, more than 2 months, and a high plasma progesterone profile greater than 1.5 nanogram per ml. So these camels are always confusing the vets and the camel breeders of probability of their being pregnant, but they are not actually pregnant. Sonographically, cysts showed hypoechogenic streaks in an anechogenic lumen in 75% of the camels, whereas in 25% of the camels, the ovarian cysts evidence anechogenic structure with a thick echogenic wall. Camels with ovarian cysts are a problem. They always confuse vets because of the cocking behavior, because of the high plasma progesterone, as if they are pregnant, but they must be carefully viewed. An ovarian cyst can be treated with 4,500 international units of HCG, GnRH, or a OVSync protocol. Camels with a palpable and sonographically visible persistent corpus luteum can be treated with 500 microgram of a commercially available prostaglandin. So, thank you very much. Kindly share the video and subscribe to my channel GN Purohit if you like them. Thank you very much.